Hello, everyone, and welcome to today's Harvard Medical School webinar. Our speaker today is Dr. Josh Mandel of Microsoft Health. My name is Stanley Shaw. I'm the Associate Dean for Executive Education at Harvard Med School. Our executive education programs at the medical school work with business leaders and companies in the healthcare industry. And our goal is to develop leaders who are expert in emerging technologies, as well as the real-world healthcare ecosystem. And we hope to prepare these leaders to apply a range of insights in the specific business and strategy context of healthcare, and of course, all in service of our patients. Some brief program notes before we get started. This session is being recorded and will appear on our website shortly. Please submit your questions if you have them. Type them into the chat box on the screen and direct them to the panelists. And so let's move on to today's speaker. Dr. Josh Mandel is a physician and a software developer who's worked for many years to foster an ecosystem of health apps with access and potential for patients, doctors, other stakeholders for a variety of uses of clinical and research data. He's currently chief architect for Microsoft Healthcare. He is also still the chief architect for the Smart Health IT project. Some of you may recognize that project based at Boston Children's Hospital and Harvard Med School. That provided some of the inner workings for why, for instance, EHR data from some health systems can now appear on your iOS device. He's also a lecturer at the medical school's Department of Biomedical Informatics. Josh, thank you so much for joining us. We're looking forward to hearing your update on interoperability and making data more accessible.
Excellent. Well, thank you for the introduction, and I'm very happy to be here. I'm going to share my screen here. And for folks who are following along, I've also included a link to the slide deck in the upper right-hand corner of the slides. So it's a short deck, but it also has links out to some of the topics that I'll be covering here. And I really wanted to focus today on the consumer experience when it comes to accessing healthcare data. So getting access to your own records and being able to share and use those records for your own purposes. And what I thought I would do was to start with kind of a set of demonstrations to make this as concrete as I can so that we've got kind of a shared picture in our minds as we talk about how this technology has evolved, where the regulations, both in the US and worldwide, have supported the adoption of this technology, where things are going. And we'll talk about both some of the trends and some of the challenges of working with these technologies for consumer data access. So with no further ado, I'm going to jump into a few demos just to really solidify examples of different modes for consumer data access. And what I'll do is actually show you some of my own records from some of my own healthcare providers, just because these are records that it's easy for me to access and things that I'm comfortable sharing and talking about. And I find that having real world examples can sometimes make this all easier to digest. So I'm going to take kind of a historical view here, starting with some of the earliest technologies that we have in place, and then covering maybe a decade of evolution in this space up to the present day. And I'll say that the first examples I'm going to show are still technology-based. But historically, the main way that patients would get access to their own records was binders full of paper and faxes. And that is still a major part of the landscape today. I don't want to downplay that or pretend that we've somehow moved on as a society. I think for many people, that is still the reality, the best, or in some cases, the only way that they can get access to their records, or the most comprehensive way they can. And I don't want to downplay that, as I said. So let's start off by looking at patient portals. This is going to be a concept that's familiar to most folks who've sought out healthcare in an environment today where healthcare providers have some kind of electronic health record system. And that's the vast majority of healthcare providers in the US today because of the incentive programs that we've had over the last decade. And I'm going to show you an example inside of Epic MyChart, because that happens to be the health record system that my primary care doctor has. I'm based in Madison, Wisconsin, so it's maybe not surprising that it's a pretty prevalent EHR system around here. But I'll start off by just showing you kind of online portal access And in my case, my records are inside of a health system called Unity Point. And so I'm able to sign in to my MyChart account with a username and password that I've set up previously. And once I've signed into a website like this, I've got access to secure messaging with my doctor. I can view information about other providers who are in the network. And I can also see things like a history of previous visits and test results and a health summary. I'm not going to belabor the point here, but I can see, for example, a history of lab tests that I've had done over the past few years. I can see the actual lab results in kind of a numerical format and some reference data with standard ranges. Some of the basics that you would expect from just getting access to my own health record in some context. And just as one other example, this is an imaging study from a couple of years ago. This was a brain MRI. And here is a good example of where some of the limits are as well, because here I've got access to information about what study was done. I've got a list of findings and an impression, but what you might expect to see here under images would be the actual MRI result. But really what I get when I click on this images link is simply a scanned copy of what looks like a fax document with exactly the same information that I had in the web table a minute ago. So what's going on here is that I've got access to a note about this imaging study, but I don't have access to the actual images, the actual MRI itself. So if I wanted to take that for an interpretation, I would struggle to do that with an interface like this one that I have here in my chart. So why do I spend time just showing you a patient portal? There's dozens or probably hundreds of these different portals today that are offered by different EHR vendors. But I want to start with this as an example of consumer data access because it illustrates some of the principles and some of the trade-offs here. So a portal provides a way for me to browse my own records. And if I want to share these records with others, maybe a new healthcare provider, or maybe friends or family or caregivers, I've got some options. I could take screenshots or print out data from this portal and share it that way. That would be an example of a very low-tech way of sharing that's still enabled by this kind of web technology. One of the really nice things about a portal like this is it doesn't require a lot of standardization. This is both a cost and a benefit, but standardization comes with its own sort of rigidity. But with a patient portal, it's just a website. And every EHR vendor can tailor it to their own unique features and design aesthetics, and they can build in exactly the functionality that they want in a pretty free-form way. So that's nice. But when I get data out of a system like this, that might make it harder to share it or harder for others to import it into their systems if there's no data standards. And so we'll get to talk about more standards-based sharing methods as well. One of the other challenges with a portal system like this is that when you're sharing information from the portal, it can be hard. I'll say here, it can be hard to calibrate trust, which is to say, if I want to share just a little bit of information from my portal account, that could be hard to do. If I just print off a page from the portal and share it with somebody, they'll have the information, but they won't necessarily know whether it's trustworthy. It's always possible that I might have tampered with that information. And for many kinds of health records, that's not a big deal. But for example, in the current discourse, if that's a vaccine record and I have a way to tamper with the result, somebody might not trust the result as much as they would if they were able to access it directly or in some verifiable way. And if I'm giving access to my whole portal account so somebody can see all that information in context, I might be oversharing. There's not a good way to select exactly the subsets of information that I want to share. And there are various tools to make these kinds of things easier, but those are some of the challenges when it comes to portal access. And then, of course, there's a couple of big ones right up front, big challenges. One is that in order for all this to work, I had to know where my data were in the first place. I had to know the healthcare provider that was offering this portal to me, and I had to pre-configure an account. So at some point in the past, I created an account there. I probably got a little sign-up code when I went to see the doctor, and then I was able to use that sign-up code to create an account. But if I have a healthcare provider that I haven't seen in a decade and I've never created an account with them before, that can cause some real usability challenges when it comes to setting up portal access. So getting a comprehensive view, remembering all the different places where your records live, and setting up accounts at those places, that can be really hard. Those are some of the limitations of patient portal access. So I want to move on, from the year, let's say 2010 to the year 2015 or 2016, where we just first started seeing health record vendors providing what we call smart app launch or API-based access. And the idea here is, as a consumer, I've got access to data inside of my health portal, and I want to share that data with an app of my choice. It could be a personal health record app, and Apple Health is a great example of an app that uses these standards on iOS. Common Health is an example of an app that uses these standards on Android, but there's many apps out there in the various mobile and web marketplaces so that consumers can decide which apps they want to share their data with, and then follow kind of a set pattern for sharing that data, and also being able to configure the specific scopes or permissions, so deciding exactly what gets shared with that app. And for me, one of the most powerful things about this kind of app paradigm is that we're not limited to some specific set of apps that have already been built. Anyone can go out and build a new app that actually meets their own needs. And some of my favorite examples in this space come from individuals who want to solve problems for themselves or for their family members. They might have a background in computer science, or they might just have a go-to attitude and put in the effort to learn what they need to in order to build a better diabetes management dashboard or build a medication management tool to make sure that folks aren't forgetting to take the meds at the right time of day. This kind of platform lets people solve their own problems, and that's really powerful. So I'll show you an example of an open source app. It's a web-based app, but it uses exactly the same APIs as the other applications that I mentioned. This is one that was built by a colleague of mine, Dan Gottlieb, as part of a research project at Harvard Medical School. It's called Procure, and this app can connect to any healthcare provider that supports these standard APIs. And so I'm going to connect to the very same records that I showed you in the Epic patient portal a moment ago. But instead of opening them directly in that portal, I'm going to connect this app to my records and get my records electronically transferred in a standardized way into this app. And so the basic workflow is you can start from the app and connect it to a healthcare provider. And then the healthcare provider will ask you to log in so they know who you are. And then they'll display to you some information about the app to say, are you sure that you want to share your data with this app? And so in this case, my Epic Unity Point portal is showing me some data about who built this app, what the app says it will do with your data, how it says it's going to use or share your information, and so on. And if I'm comfortable with what I see here, I can continue. And if I'm not comfortable sharing, I can deny access. But for this demo, I'm going to go ahead and continue. And then what I see is I've got sort of a choice of data categories. So this app is asking for or requesting information to all these different data categories. If we would like information about my allergies, my demographic information, any documents and health issues in my record, then I can individually select these to say, well, I don't want to share my immunizations, or I don't want to share information about my medications, because maybe this is just an app that's helping me track my weight over time, or track my BMI. And maybe I don't want to share all these different modalities of data. So I can individually make these choices. And I can also make choices about how long the app will have access to my data for. I can create a short-term connection, which is what I'm doing here. But apps can also get a long-term connection so that they can stay up to date with my clinical records if I'm comfortable making that kind of persistent access grant. So in this case, I'm just going to click allow. And I'm going to be sent back to the app. Now, at this point, the app has got what's called an access token. It can make standardized API calls to fetch my data in a structured way. And this app is really a tool that's pretty low level. It's just going to show me the detailed data so that I can review it and I can just sort of go through my records one by one. And I'm not going to go into a lot of detail on these data formats, but they use a standard called FHIR, Fast Healthcare Interoperability Resources. I'll say a little bit more about that when we talk about regulations. But I can sort of browse through these resources, different observations that were taken, encounters, diagnostic reports. And as I drill into them, I can see details like, here was a blood pressure measurement that was taken. I know it was about me because it's got a link to my patient record here. I can tell which healthcare provider took the measurement. I can see that I was in a sitting position when the measurement was taken, and so on. So these are the kinds of structured data that you can get out of an API like this. And this tool is really designed to give individuals a way to gather all their data in one place and then either download them in a file, export them into spreadsheets so that you can easily track your own trends, or to share your data with a research study of your choice. And this was one of the main motivations of building an app like this, was to provide a very simple workflow to help individuals collect their data in one place and then share them with a research study. The other feature this app has, which I kind of enjoy, is for folks who don't mind sharing their health data publicly, and I put myself in that category, they can upload those data to GitHub, which is an open source hosting environment, and individuals can just make their data available to the world. I have found that this has been really helpful with my own records because we're often starving for realistic examples when we work together in the health standards community. Developers are very interested to know what real world data look like, but most real world data are rightfully protected very strongly. So by publishing a little bit of my own data openly, it makes it easier for developers to learn more about how these standards work. So what I just showed you is a pattern called OAuth. It's an authorization pattern where you can connect an app of your choice to a data source. And so in this example, I connected the Procure app to my health records at UnityPoint. This is a pairwise connection. So if I wanted to feed data from multiple providers into my app, I would go through that same connection process multiple times, one for each provider that I wanted to share from. And then for each of those connections, I would be able to set these kinds of access scopes to decide what data to share. So the nice thing about this is I've got that kind of control. I'm guided through the connection process. So I don't need to go and take many different steps browsing through a portal on my own. Each step leads into the next step. And so I'm sort of taken through a wizard-like step-by-step process for sharing. And the really powerful thing here is that a marketplace of apps can and has emerged. We see consumer-facing apps, which is my focus here, but these same standards are also being used for provider-facing apps. And then the last example that I'll show you is a project called Smart Health Cards, which launched just this year, which is a way to address some of the trustworthiness or verifiable data concerns that I mentioned when I talked about sharing in the portal use case. And so here I want a way to share my COVID vaccine results. I don't necessarily want to share my whole health history. I just want to share one small discrete piece of data. And so I'll go back to the MyChart example here. I'm going to show you Epic has launched support for this feature, as has Cerner and Athena Health, and also many of the major pharmacies, so CVS, Walgreens, Walmart, and on and on. This is also a standard that has been adopted by several states. I think we're up to 16 states that support this Smart Health Cards standard. And Massachusetts is one of them, for example. The idea here is that individuals can get access to a very limited set of their data in the form of a QR code, like the one that I have on the screen here. And this QR code includes information about my 3 doses of a COVID-19 vaccine, information about where I got the vaccine, which dates I got it, which vaccine product I received. And by letting somebody scan this code, I'm allowing them to see that information about myself together with my name and my birth date. So it's a very well-defined, narrow package of data that can be used for vaccine verification. And for folks who want more information on this front, it helps if I spell the word smart right. smarthealth.cards is the sort of consumer landing page that explains how this technology works. And if you're interested in getting this kind of QR code for yourself, there's a list of all the different participating issuers. We estimate that there's on the order of 150 million folks in the US and beyond who have access to their healthcare data in this format today. So this has been an incredible experience for me over the past year, developing these standards for smart health cards. They've been deployed very rapidly by public health authorities, as well as by pharmacies and EHR vendors, because they solve a real world challenge of being able to share this kind of health data. And they solve it in a flexible way so that we can start to account for more data, not just COVID vaccines, but lab results and other small sets of clinical data when it makes sense to share. And this is a technology that can also be used offline. So you can print out that kind of QR code on paper. Some healthcare providers are starting to print these out on little stickers that they'll give to patients at the time of a vaccine. And the great thing there is you can just take that piece of paper with you and let somebody scan it when you want to share your data. So these are 3 examples of technologies that allow consumers to access and to share their own records. I want to spend a few minutes and talk about, why is this happening? It's been a fair amount of change over the past decade. And I think probably the prevailing factor here has just been broader growing consumer expectations from domains beyond health. But every aspect of our lives today, we expect and we should expect that there are good online services that make data access easy and that make data sharing easy and that provide user experiences and choices of different apps that can help us get our jobs done. So healthcare should be no exception, although historically technology in healthcare has moved much more slowly than technology in other domains. We've seen a long-standing investment across multiple administrations at this point, investing in this kind of health technology. And it's actually been pretty incredible to see the through line of support for these standards-based healthcare data sharing paradigms. The Office of the National Coordinator for Health IT has been in charge of setting the technology policy here. And there's two technologies, two standards that I'll point out for folks who are interested in digging in more here. One, which I mentioned, is FHIR, Fast Healthcare Interoperability Resources. And this has been an incredible community effort to use web-based standards practices to represent all kinds of healthcare information. Clinical data like allergies and medications and problems, diagnostic and medication data, healthcare financial data about claims and insurance coverage. It's a really rich set of data models that allow health systems to represent the information inside of their databases in a standard way so that it can be shared across boundaries. I don't have time to dig in today, but I wanted to mention it for folks who want to learn more. And then the other standard, which I demonstrated earlier, is that Smart App Launch, which is a standard for connecting an app of your choice to your healthcare records. And so these standards go hand in hand together with the Smart App Launch workflow and the FHIR APIs. An individual can make that connection and get standardized data flowing into the apps of their choice. But just having a set of standards and making them useful or easy to use is not nearly enough. We've also had a deep investment, as I mentioned, on the policy side. The 21st Century Cures Act has set up a few important expectations. One of those has been the idea that authorized users should be able to access these kinds of electronic health information without special effort using standardized APIs. And then the Cures Act left the details of that process to be worked out by the Office of the National Coordinator for Health IT. So there's two important aspects here that I'll mention briefly. One is the EHR certification program. And basically, every major electronic health record product follows these certification rules. And ONC has expanded these certification rules, published in 2020. And there's a few important items on this timeline for certification. The ones that I'll point out here are the ones that take effect at the end of this calendar year. So by the end of December of 2022, every certified EHR needs to support these Smart on FHIR APIs that I mentioned. So I happen to have access to these APIs already today. I think probably over 100 million Americans do have at least access to one source of data with these APIs today. But by the end of this year, every certified product needs to support these APIs and make those updates available to the healthcare providers who are using those products. So even though this technology has been around for 5 years or so, it's finally making its way through this certification pipeline and becoming a requirement this year. So that's huge news from my perspective. It's something that hasn't come easily, but is going to give us an incredible scale of access. And then hand in hand with those technology requirements are these what are called the information blocking rules. And this is the other really interesting thing about the Cures Act. It sets up the expectation that authorized users should have access to health information that they're authorized to see, and that any activity that prevents that access might be considered information blocking. And there's a number of exceptions, which I won't outline in detail, but this sort of flips the HIPAA model on its head, where HIPAA talks about when it's okay to disclose things. These information blocking rules basically say that by default, you need to share information with authorized users. It's not your choice to pick and choose which users you want to support and which ones you don't. By default, if a user is authorized, they're supposed to be able to access this information, and anything you do that prevents it could be information blocking. And of course, there's a number of exceptions in place for things like privacy and security and feasibility, which we could dig into later on when we talk about some of the challenges. But this is really a paradigm shift in terms of switching the default from off to on. All right, I want to spend just a few minutes and talk about some of the trends and the challenges. So I mentioned these certification rules are really coming into effect this year. So what's next? So one is the concept that ONC has put together called a core data set. We put more and more information into our electronic health records over time. And as the science of medicine expands, there's more different kinds of information that we have. So as a starting point, the federal government has declared what's called a core data set for interoperability, which covers the kinds of information that are broadly stored in health record systems and that should be broadly standardized. And the initial version of this US core data set had things like medications, problems, allergies, immunizations, lab results, many kinds of clinical notes, and so on. And the idea is that each year, or roughly each year, ONC will update this US core data set to include new types of data. So right now, we've had the US CDI version 2 published, which includes new data types around social determinants of health. And we have a draft proposed for the US CDI version 3, which continues to expand the data set. So folks who are interested in sort of seeing how these data will improve over time or grow over time, the US CDI is a thing to look at. But I also want to mention some challenges here, which is that not every piece of health data can or will be standardized anytime soon. And the scope keeps growing as medicine grows. So there's also a requirement in these certification rules, which is less standardized, but in some ways more powerful, which is called EHI export, or electronic health information export. And the idea here is that consumers should have a way of getting everything in their health record, even if it's not part of a core data set, and even if it hasn't been standardized. So this is what I like to think of as the escape hatch that will, by the end of next year, in the current timeline, allow any individual to request a full export of their data. And so that's something that I'm looking forward to because it will fill some of the gaps that we might never meet in our standardization process in a really effective way. But there are also some challenges here, and one is sort of automation. There's no workflow built in to support that kind of individual access. And so it might involve clicking through different screens of a portal in order to find that export functionality. It might not be an easy thing for a consumer app to kick off this sort of export job. And so we've been working with the community to expand the workflows there and make that export easier to do. And then the last trend that I want to mention in terms of more access is a project called TEFCA, the Trusted Exchange Framework and Common Agreement. This has been a long-term policy objective from ONC to expand a network around the US of healthcare providers and other entities who want to be able to share and exchange health information at the individual level. And as of just a couple weeks ago, this common agreement, sort of first version of the common agreement, was finalized. And the basic paradigm here is there's these networks of technology providers who offer services to healthcare providers who in turn can write queries into the network to say things like, hey, is there anyone named, do you have records about anybody named Josh with such and such a birth date who lived at such and such an address? And those queries are broadcast out into the network. And then providers who are part of that network can respond with the data they have about an individual patient. And so the TEFCA stands to provide a common agreement, common framework for sharing these kinds of data at a scale that we haven't seen before. But I will say there are some real challenges here, and some of them from my perspective have to do with privacy and transparency. So a network like TEFCA kind of expects that these queries should be just broadcast out to all the healthcare providers, and then anybody with relevant information can respond. And when you think about how individual consumers get visibility into that system and how they can manage and control what gets shared, it starts to get very challenging. So TEFCA provides a really different model than something like the system that is beginning to emerge in India as part of their national digital health mission. So I'll just briefly mention sort of this other architecture, which other countries are starting to invest in, which really puts the individual at the center of the picture with a component called a consent manager. So you can set up policies in one place, and then rather than a healthcare provider broadcasting a query out to thousands of other providers saying, do you have any data on this patient? Instead, they can talk to your consent management tool, and your consent management tool can make the connections to the specific endpoints that you want to share from. So this is a very different paradigm from TEFCA, and one that, from my perspective at least, provides much better transparency for consumers. I'll just very briefly mention two more trends. One has been the ability to kind of close the loop of data access. So all of our standard APIs are based on helping individuals to read data from health systems. But now that more apps are starting to bring data together from multiple places, including data captured from individual fitness devices and trackers and smartwatches and so on, examples like Apple Health are looking at ways to return this information back into the clinical workflow. So this is an example of an app that Apple has built where they can connect the different health records using Smart on FHIR, and they can also put a dashboard into the clinician-facing EHR view that shows a summary of things like heart and ECG data from at-home measurements, or weekly activity in terms of how much exercise patients are getting. And so using these same APIs to return information into the clinical workflow, I think, is a very important trend. And then the last one that I'll mention is very early stage work, trying to automate more of our HIPAA rights. So data access is a right under HIPAA. Individuals have a right to access their own records. But there are a couple other really important rights today that are way too hard to exercise. So one of these is amendments. When you notice a problem or an error in your own record, how do you request that that problem be corrected? So today that often involves faxes and phone calls, and it can be very hard to monitor the status of those requests. There's great work going on right now within HL7's patient empowerment work group. So HL7 is the major healthcare standards development organization, and the patient empowerment work group has taken on this problem of HIPAA amendments or corrections to say, what if we had an automated API so that my apps could help manage these correction requests and point out problems where my healthcare provider might have details of my health records wrong. So I think this is a really interesting trend, but it's still early days, and it's not an area that healthcare providers have yet been particularly excited to engage in. So we're starting to see the standards get ahead of the real world implementation. And that's just one challenge that I want to call out on that front. So that's all the content that I want to talk through. I'd be very happy to take questions or comments from the audience. Really excited to engage on these points.
Great, Josh. Thank you so much. That was a whirlwind tour, but it's actually really exciting to see the progress that's been made. Let me just start with a few questions of my own and also from the audience. I actually think you covered some of their questions already. Can you give us a sense of, in terms of smart apps, what's the extent of uptake so far? How much traction are they getting? And, I assume there's going to be some kind of network effect as more health systems participate, and how far do you think we are from that point?
So I think we're still at the very early days. And the best examples that we have of apps today that are in relatively broad use are things like Common Health or Apple Health that are kind of, I'll say generic personal health record tools. They bring together your data from many sources and just sort of display them. And that on its own is a kind of value proposition for many people who just want to have an organized way to track their own health history. But when you start digging into it, I think the really interesting applications, the ones that maybe move the needle more, are going to be the ones that help people get some urgent job done. And so that could be disease management. So this could be apps that help me, take better care of my diabetes, or it could be apps that help people navigate the health system. And I think this is something that is just so front and center in the consumer experience for me today, which is, how do I find a healthcare provider who's in network? How do I find somebody who's a specialist in the problems that I am looking for treatment for? How do I schedule an appointment with somebody? And maybe there's nobody nearby and people are booking appointments 6 months out, but there's one provider who would actually be a good fit, but it's just too hard to find. So I think apps will make all of this a lot easier, and with better connectivity into individual level health data, as well as better connectivity into some of the pricing and benefits transparency from insurance plans. Apps that start to integrate those kinds of data feeds are going to start providing, I think really useful tools.
And for what you were just saying, is something like Smart on FHIR going to be a vehicle that can really help with that and kind of bridge, some of these data type access issues onto personal smartphones?
Sure. So I think, we're already starting to see examples like this in the space of insurance plans or shopping for the best insurance plan for you. In theory, the way that you would shop for a plan would include some understanding of your own healthcare usage patterns. What kind of care have you needed, together with your demographics to sort of make predictions about what care you might need in the future, and then shopping for a plan based on that information. So CMS today supports a Smart on FHIR connection to get data about your own insurance coverage and about your claims history, what are called explanation of benefit data, so that you can connect an app using the Smart on FHIR APIs to a CMS system that they manage centrally for Medicare fee-for-service patients. And they've also set up the requirement that other insurance plans that participate in these Medicare Advantage systems will also offer those same kinds of APIs. So just the same way we use these Smart on FHIR connections to bring clinical data into these tools, we're also seeing a pathway for healthcare insurance or healthcare financial data to be brought into these tools. And I think that's a really powerful kind of panoptic view.
And can I pick up on this theme about the API? So, just because the capability exists to open up these APIs doesn't necessarily mean that people feel like they have an incentive to open up that API, and there are costs involved in, what do you think we need to do to help this idea of APIs scale more broadly?
Yeah, so I think one of the most powerful components of the current regulatory landscape is the way the ONC has set up these requirements. Every health record system has to support these APIs as a native feature if they're going to go through ONC's certification program. And this ties together with CMS requirements that most healthcare providers who are participating in any CMS program need to use a certified EHR. And so this is kind of the 1-2 punch of you've got to use a certified system, and the certified system has to support this kind of access. So that's going to help a lot with distribution. The other side of it is that when it comes to patient app connections, healthcare providers are not allowed to charge patients for the privilege of bringing their own data into an app of their choice. There's no kind of pass through back to the patient or back to the patient app that's kind of built into the landscape. Those same APIs can be associated with fee structures when they're used in clinician-facing apps or other use cases beyond patient access. So this creates the opportunity to use the same technology in a revenue-generating way for some use cases, and in a data liquidity promoting way for other use cases like consumer access. And so from my perspective, the fact that we've been able to define one set of APIs that solves both of these problems is really powerful because we can ride those rails into more broader deployment.
Great, thank you. So there's one question about patient data ownership as opposed to access. And so what's the status here?
Yeah,
there's
so
ownership and then there's control, but speak to whichever of those.
So this is a very complicated set of questions that can differ place by place. Maybe the most general thing to say is in the US overall, like most healthcare providers are HIPAA covered entities. They have certain obligations to store and manage records about individuals. They have to keep them for a certain amount of time. They maintain the integrity and audit logs over access to those systems. So they're very much institutional data. And then consumers or patients have a right to access those data. There's a couple places where there's stronger rules about data ownership, although even in those places, the interplay between those rules and the baseline HIPAA expectations is not that clear. So for example, in a state like California, where we have CCPA, the Consumer Protection or Privacy Act, for most kinds of consumer data outside of healthcare, individuals have a right to be forgotten. So if you're working with some business that's got records about you, you can call up that business or fill out a form on the web and say, thanks for all the services you provided me, please delete me from your database. And that's binding. The organization has to follow through on that request and let you know they've done it. But in the healthcare space, those rules don't quite apply because there's other obligations that require those organizations to maintain records. So ownership is a complicated topic. And it really comes down to the underlying laws and regulations that vary place by place. But access and the ability to delegate and share access is a consistent right. And so that's been a strong focus for national policy.
Great. So there's one person who's very happy with the smart vaccine verification, says it's been a great success in San Francisco and California. And he's wondering, how can we kind of ride that momentum? Like with the success of the smart vaccine, will that lend itself to other applications soon?
Yeah, so this is a really exciting area for us in the coming year. I've been working closely with an organization called VCI, which is focused on verifiable clinical information, which sort of brought together the community that helped write these specifications and has promoted adoption. I'll say in the near term, there's a couple of, I'll say, very natural extensions to this work. One of which is just vaccine records for more vaccine types. COVID was the use case that got everybody interested and got triggered very rapid deployment. But now that public health authorities in over 16 states have built support for this, and the major pharmacies have built support for this in the COVID use case, it becomes a very easy thing to say, well, all of your vaccine records can be represented using these QR codes and using these same standards. And so for things like kids going back to school and needing to show records of vaccines, historically, that's a really challenging problem. The approaches vary state by state. So in some places, the school has to go and connect to a state system and get the data from that registry. But if you moved states and your kid's data is not in that registry, maybe you're faxing doctor's notes back and forth and the school doesn't want to take your word for it. So they want to, all these things are very painful. And so if we just had uniform access to vaccine records with these standards, that's already a very strong step forward. And similarly, I think there's going to be a strong push on testing results. So in the COVID space, at-home diagnostics, as well as PCR tests that you might have done in a lab, sometimes you need to display those results in the context of travel or in the context of meeting an employer's requirements for testing. Rather than having a million different workflows, we can represent these testing results in a standardized QR code. And that's another very natural extension for the smart health cards work. One of the limitations of this technology, though, kind of no matter what you do, is the fact that QR codes are a limited capacity kind of standard. You can fit maybe 4 kilobytes of information into a QR code. Plenty for sharing a few vaccine records or a lab test, but not enough to share like a medical history summary or the full set of relevant immunizations that you've had across your lifetime. So we're also doing some work in a project that I'm calling Smart Health Links that sort of looks and feels very similar. It uses QR codes to share data, but rather than embedding all the data directly in the QR code, Smart Health Links is looking at how can we make secure links to data that are hosted out on the web. And some of the exciting things there are that the data might change over time. So I might share a link to a feed of my most recent test results. And then as I have new tests, that feed can be updated. So that's a potentially very exciting direction to go. But it also introduces new challenges because those data need to be hosted on the web. The components need to be online. So I think we'll start to feel out what are the best fits for these different use cases.
Great. So maybe I can ask kind of a future-looking question for the last question. And so we're now seeing, this growth of telehealth companies or virtual health companies. Increasingly, you can get elements of your care at a CVS or a Walmart. And so the location of this data is more fragmented, more distributed. Is this interoperability edifice of standards and APIs, are we ready for it? Or do you anticipate some pain? And what do we need to do so that that future vision of distributed omni-channel care, so to speak, can have the data go where it's needed?
Yeah, I mean, I think, look, we've already got all kinds of pain. I do anticipate there will be some new kinds, but I think we'll also smooth out some of the old kinds. So I think that in the near term, this fragmentation is not so much of a worry for me. There's 2 possible answers that we have kind of architecturally. One is the TEFCA vision that I mentioned, which is, doesn't matter where your data are, everybody's part of this trusted exchange network and they can always just look it up. If it wasn't clear, I'm personally pretty skeptical about that model. I think it's got technical challenges in terms of false positives and false negatives. It involves a lot of patient matching. I also think it has real privacy and transparency challenges. But I mean, this is a national objective, and I think we will make progress on it, and there will be more exchange that happens in that way. And it can help smooth over some of the challenges of fragmented data. The other model is really this consumer-controlled model, which is I can bring my own data together from several places. If every time I get some care at a CVS or a Walgreens, I get an after visit summary that's forwarded to me automatically, and that starts to grow in a virtual file folder of my health records, and those things are standardized and they travel with me, then it becomes easy to share that whole folder anytime I see a new clinician. And I can share everything, or I can decide to share only the things that are relevant to a particular diagnosis. And it can also help me with intake. So maybe I'm going to see an endocrinologist for a new problem, and they've got 35 questions they want me to answer. That questionnaire becomes a lot more straightforward to fill out when it can be powered by a detailed structured health history that I carry with me. So none of these things are trivial. I don't mean to say that magically we'll turn on this technology and these problems will be solved, but the more tools we have and the better data flow we have with transparency and consent, the more we'll see individuals and organizations starting to build better tools to solve these problems for themselves.
Yeah, great. And certainly, if I think back maybe 3 to 5 years, there's really been a lot of progress that's gotten into a lot of individual patient hands and people's hands. So excited to see the momentum continue. So Josh, thanks so much for lending your perspectives and giving us, a mix of the practical and the standards and all of these perspectives. If you are interested in exploring how to apply or look at some of these digital health topics in the broader context, we do have an upcoming program called Leading Digital Transformation in Healthcare. It kicks off on February 7th. Oh, thank you, Natalie. There's a link in your chat. Our next webinar will be on advancements and challenges for deep learning in medical imaging, Wednesday, February 23rd, also at noon Eastern. Our speaker will be Pranav Rajpurkar. He's a faculty member at Harvard Medical School's Department of Biomedical Informatics. He's also a podcaster. He's one of the developers of the popular Coursera series on AI in medicine. Look for that link. And again, that's February 23rd at noon. Josh, thank you so much for joining us. Everybody listening, thank you for joining us. We look forward to seeing you again. Enjoy the rest of your day and stay safe. Take care.
Thanks. Take care, everyone.